Well, we are happy to have our last speaker, that is Professor Colin Fleming. Professor Fleming is a consultant dermatologist at Mohs Surgeon and an honorary professor of dermatology and innovation lead in NHS Tayside, and he's based at Ninewells Hospital and Medical School in Dundee. He has been a consultant in Dundee since 1999.
I think Amelia was frozen there for a second.
Excuse me. So I can go again. Professor Fleming has been a consultant in Dundee since 1999 and has set up multiple services for skin cancer patients, including the NOSCAN Macmillan Mohs service. He's a former president of the British Society of Dermatological Surgery, former president of the Scottish Dermatology Society, and was operational medical director in NHS Tayside from 2018 to 2021. His interests are in health informatics and has been active in development of electronic patient records and created Dermabase, a web-based diagnostic database for dermatology. He's innovation lead for NHS Tayside and research lead of the NHS Scotland AI Skin Cancer Consortium, which seeks to establish diagnosis by artificial intelligence of skin cancer in Scotland within 25 minutes by 2025. So as I said, we are very happy to have Professor Fleming with us, and the floor is yours now.
Thanks very much. Can you see my screen okay? Great, yeah. Thank you. So thanks very much to the two speakers so far, both really good talks. And I guess what we've been able to do is really begin to understand, first of all, about biases within data sets, and then get into the idea really of what data sets look like, the public available data sets, where they're strong, where they're weak, and get into concepts such as health data poverty and digital health inequality. I guess one of the things that will come to the end of this talk is how we can begin, therefore, to talk about how we can overcome some of these obstacles. But what I'd like to do is really just talk about some more broadly applicable principles, which I think are important when your researchers are working in this area, thinking about data sets in human populations. And some of this will probably overlap on what we already discussed, so I'll probably go lightly on that and spend a little bit more time on things that we haven't really discussed in detail so far. I'm more than happy to be interrupted midway, halfway, quarter way, or any way you like, if that's helpful, because sometimes it can make the whole experience more interactive. I guess we're all starting from the same starting point, where we know that there's been lots and lots of publications, and perhaps as many as 2,000 groups working worldwide on AI. And on the one hand, we've got this interesting juxtaposition where myself and two other speakers today are telling you where we're really not very good at AI and where our problems lie. And yet, on the other hand, if you go on to the Apple Store today, you might find in the UK 50, 60 apps which claim they use AI to diagnose your problem for you. So why have we got this contradiction, I suppose, is part of the question today. So going back, I think, without going over all the literature, but really one of the most important papers, I think, in general terms for setting the work today is the Nature paper from some years ago now, but really the first paper which demonstrated that AI could do things in a particular fashion as well as humans. And this was classification of lesions using just a single neural network. So nowadays, if we're doing studies, I don't know what my colleagues do, but we would often have multiple neural networks running for any experiment, and giving different examples, both Bayesian and non-Bayesian networks running. We would, in this study, we saw just really pictures and disease labels. So there wasn't any additional information, and that's many of the studies being published have worked on just pixels and disease labels, which is not a bad way to start, but perhaps doesn't give you all the answers as we're already beginning to uncover. And it was a sizable data set. And it's important to understand that they tested the performance against humans in a very particular way in this excellent paper. They looked at a binary classification. What they were talking about is, let's look at things which look very benign on the skin, and let's look at things which look cancerous in the skin. So they're trying to divide malignant into non-malignant, and they did that in two ways, looking at melanomas, which you're probably familiar with, versus things that look like melanomas, and looking at basal cell cancer and squamous cell cancers versus benign seborrheic keratosis. And essentially, in this very defined way, the AI could work to the competence of comparable dermatologists. And one of the very useful things about this was beginning to understand, when you've got your data set, how you can classify that data set in such a way that it allows the researchers useful information, such as benign versus malignant. And if you start with these sorts of concepts, then you can move gradually into improving the accuracy of your algorithms into becoming not just selection tools, triage tools, or patient support or clinical support tools, but eventually into diagnostic tools. So even this excellent landmark paper didn't actually give you anything like a diagnostic tool the way that you might want. So a summary of certainly the UK field of where we are in artificial intelligence with skin cancer now is in this position paper from the British Association of Dermatologists, which was really puts some fairly obvious comments out there. One of them, which is the evidence base for effectiveness of intervention in dermatology, is limited. And it's limited because the studies being taken are in relatively artificial conditions. If we were to look at the analogy with bringing an AI tool to market versus bringing a drug to market, both, when they get things wrong, may have catastrophic consequences for the patient. If you take a drug to market, you go through in the UK, a very standardized process. Most of the world is similar, where you'd go through phase 1, phase 2, phase 3 studies. And the phase 3 is the bit where you'd use those in clinical conditions, which try to represent what's happening in the real world. If you try to have an analogy for this in the UK, essentially you don't get much beyond a phase 2 trial when you can get a marking for your product and have your product approved without any real world use. So mostly the devices which are given a license in the UK are actually not fit for purpose because they haven't been tested in real world situations and understood in real world situations. So this allows, first of all, an uncertainty about what products are useful. It really makes you understand that you need to develop really rigorous test beds across wherever you're working to actually bring in AI in real world situations. And if we go to a more advanced area of AI, such as breast cancer screening, where in the UK there's something like 40 applications available now, we're using those in test bed situations. We've got a project going here locally where we're basically running the AI against the clinicians, comparing outcomes and using these licensed products in a real way, the way that you wouldn't do with a medicine, because a medicine's already gone through this by the time you're allowed to prescribe as a doctor. So the summary really where we are of skin cancer AI in the moment in the UK is that we are concerned, I think, collectively, that we don't have products which work well enough yet and we need to improve them more. And I think if I make a comparison with other areas of AI that I have some tangent involvement with, is that if you look at something like radiology, there's a long-standing set of protocols in radiology which allow you to capture images in a standardized way. That doesn't exist in dermatology. And if we look at pathology, which is relatively new, we've invested somewhere upwards of £10 million UK. That's what, 12, 13 million euros, or probably about $10 given the rate of the pound to the dollar these days. But nonetheless, we've invested a lot of money in digitalizing pathology, and we've ended up with our pathology slides being not particularly usable and our pathology AI not working well because we haven't a unified system, standardized system for bringing that data in and presenting that data. So standardization of all elements of all pathways in the real world will be required to be to produce data which you can use for AI, not just training AI, but actually running that AI. It's got to come into you. So if we think about radiology, yeah, there's a lot of standardized data there, and that's one of the reasons why they're ahead of the field. We think about something like pathology, more like dermatology, and a lot of uniformity required to be brought in. If we think about skin disease, we've got lots and lots of differences and variations, device, lenses, techniques, lighting, sites of capture, metadata, transfer software, protocol storage software, the list goes on and on. There's an awful lot out there before you get your database, which needs to be standardized. And it's nice to develop a beautifully highly curated data set such as Isaac dataset, but actually when you're working as a doctor and you're trying to create AI in real world data sets, you're going to have to standardize all these elements or think a way around about it. So here's two examples here on the left hand side, some of the data we might deal with, really high quality data with high quality Dermscope. And on the right hand side, some of the dirty data, as we would call it, variable quality data coming in from primary care across our region of all sizes and shapes. And some of it incredibly useful to the teledermatologists. And actually, we know that some of our AI can use some of this poorer quality data with quite good effect in some circumstances. So all data is interesting, but all data to be really useful needs to be standardized. There's a general point also when you're working and preparing data sets about how that's done, because if you are working in the academic sphere and you've got time to create data sets, you can create beautifully highly curated data sets, but if you're working in some of the dirtier data that comes in the real world, it does present problems for you, which you don't come across, perhaps, so often in the curated publicly available data sets. So here's just one example of many that we have. This patient's been referred for vetting by the Consultant Dermatology team, and the lesion was about a history of something new happening the last couple of months. So at the time that the clinician referred, put a diagnosis on that, it was thought to be uncertain. So they said, well, we'll vet this into the routine part of the skin cancer service. And by the time they arrived in clinic, a few weeks later, the lesion had spontaneously cleared. Then we know that the patient that previously had a basal cell cancer at a similar site. So what's your diagnosis? You know, we probably would just, all we can say is condition cleared, but for the AI, that presents a problem, presents uncertainty around about that. So it's just an example, I think, of some of the grit that you get into when you're dealing with real world data sets. I think a second point really that we have to think about is how easily we can manipulate data. And this is a point really not so much about the error and biases, but actually of the data sets themselves, but more to do with error and biases perhaps of the investigators. And there's no doubt that it is possible to manipulate your AI algorithms in such a way that you can make your data look very, very good indeed. And this is one of the reasons why some tools are coming to the market. So just give you an example of some of the AUCs that we're looking at in a couple of select situations from our own work. So this is trained on ISD 260, so that's publicly available data set, 260 different diagnostic classifications in it. And if we look at this, I'm sure you're probably all familiar with this, but just a reminder that on the left-hand side, we're looking at the false true positive rate, and on the horizontal axis, the false positive rate. And we can play with this data so that if we decide, for example, to exclude for every 100 lesions, the 80 most difficult ones, and just deal with the 20 that we really like the look of, we can do two things. We can, first of all, give you an almost perfect, look at that, almost perfect right ankle at the top left-hand corner there, which would suggest we're absolutely brilliant at what we do. And second thing, therefore, we can take this to a regulator or take this to somebody who knows a little bit less about AI than people on this call and say, look at our fantastic algorithms, look what they can do. We should take this to market, shouldn't we? You can also say, claim legitimately that if it's a triage tool, and if it's supported by teledermatologists, which is the way that some things are coming into the market in the UK, then you can claim that this is a safe way to do things, because you can say that 20% of the workload has now been dealt with by the algorithm, and the other 80%, well, we're not sure about that, so we just send that to teledermatologists. That could be an argument for reducing 1/5 of all the workload in dermatology departments. So, important to think about this manipulation. That's probably, I think, manipulation which we need to understand, and it's probably something which has subtlety about it, but it is something which can be used by companies in a way which is perhaps a little bit unfair and gives them a very pro-marketplace sort of solution. However, you can manipulate your data in different ways. So this is something our group's been involved in, where we're trying to improve the consequences of AI decisions through weighting skin cancers differently from benign lesions. So what do we mean by that? We mean essentially, we use a classification where we don't regard getting a simple benign lesion, let's call it a wart on the skin. We don't regard that as the same error of the same magnitude as missing, let's say, a melanoma. So we introduced a set of predictions where we penalize heavily missing something which is life-threatening, and we penalize with a very low penalty something which is a benign lesion. So there are other ways of manipulating data which can be very helpful for the researcher and can actually bring about better use of algorithms. So if we begin to play around with various different data sets, we can begin to, this is one example, we've trained on our Isaac data set and our SD260, then we've tested on some local dirty data, and we can see the 20% coverage. That's okay, it's not that great. But then you begin to fine tune it on the local data, some of the data which we're dealing with, not great quality data. We're not interested in great quality data in this particular set of experiments. But then if we begin to look at 20% coverage and playing around with the data using using classification and asymmetric classification, you can see you can begin to improve the quality of the AI algorithm. This is experimental, this isn't meant for real world use, but it tells you how you can begin to play around with this selective classification. So we're really talking about manipulation of data sets as a second point, and how the researcher can really play with those and how that can affect real world use of AI. We've already actually had a lot of presentations, so David's presentation was excellent, really. I'm not going to go into any more details about that, but I guess one point I would make is it's sufficiently important, this work, that it's coming up in multiple areas, and that it creates this real issue about lack of adequate both clinical metadata and representative data from, not just clinical metadata, but representative data from various parts of the systems. So in our area, we have areas of significant poverty, and we have areas of significant wealth, and we have quite different types of images coming in from those two areas. So we've just gone lightly over that issue because it's already been discussed in David's talk. The next issue, I think, when we're talking about data sets, is really understanding where the algorithm is going to be used, the use case understanding. The use case understanding for me is something which is not really fully understood, and I certainly see quite a lot of commercial algorithms claiming a widespread ability for a single algorithm, single product to work in a number of different situations without clarifying what those situations are. And I think it's really important that you guys out there understand the situation in which you use your algorithm. It's really, really important. So the performance of an algorithm is entirely dependent on the use case. So if we think about, and I think a lot of clinicians learned quite a lot about this during COVID, how as COVID incidence was going up and going down in the community, the relative chance of a positive test would go and fluctuate with that. So we talk about the positive predictive value, and I'm sorry if I'm going over stuff which is you're very familiar with, but a reminder that that's the probability that a positive result accurately reflects the presence of a specific disease. So that's going to be the number of true positives over the number of true positives and false positives. So therefore, the disease prevalence is very important. Let me give you an example. Let's say we've got a population being referred up to hospital, and of this population, of a a few hundred lesions. We've got about 160 skin cancers which test positive, 40 which are test negative, so our AI algorithm gets 40 of them wrong. Of the benign lesions, we get about 80 which test positive. So it's got a high sensitivity, this for picking up disease, and it doesn't want to miss anything, so it picks up 80 benign lesions. And there's the true negatives are about 270 in this set. So if we work out our predicted value plus predicted value, we might get a figure of about 67%, the true presence of disease in that population. So that's a not unusual secondary care population. But if we think about a primary care population, we would have far fewer skin cancers, many, many more benign lesions out there. The average GP in my area in Scotland might see a melanoma once every 5 years. A primary care practitioner isn't going to see many melanomas, but every day of their life, they're going to see many, many benign lesions. So this is a somewhat conservative calculation, just changing the figures around. And you can see the same algorithm gives you a positive predictive value of 8% in this case. So the true ability of the test to pick up the disease is about 8 in 100 in this case. So we've done some work with the University of York, and this is with Rebecca, who works along with David, working on a more detailed analysis of what I've just shown you, taking a hypothetical cohort of 100,000 lesions and setting various sensitivities. Let's say the app is sensitive at 95%, specific at 80%, and there's 300 cases of skin cancer in the population. That gives us, this is roughly a better estimation of what your secondary care population might be. So your true PPV might be 12.8% in this population, but if we use the algorithm in the primary care population, we get something like 1%. So you're actually getting a test which is really not very useful at all, and is creating quite possibly a huge amount of extra work in the system. So it's very important to understand that we have use cases which are very different in picking up skin cancer, in which your tests will behave in different ways. So if I have to monitor myself with my own images and do serial monitoring, it's going to be different from a primary care practitioner. It's going to be different from a secondary care practitioner being referred things from a primary care practitioner, which is going to be different from a secondary care practitioner working in a tertiary institution. So there's a whole lot of possibilities for skin cancer diagnostic tools, but they will all work differently. And the paper alluded to by David, Wynne Jones's Lancet Digital Health, points out of the 14,000 odd studies, actually only 2 studies use data from clinical settings which resemble a primary care setting. That is a setting below prevalence of skin cancer. So we actually have very little information for some of these use cases. That doesn't stop, however, companies coming into the field and claiming that their algorithm will cover all use cases. So really important to understand that the performance of an AI algorithm is entirely dependent on its use case. So here's a list of some of the use cases we've worked through with Deloitte through our AI Skin Cancer Consortium. And you can see all of these use cases we've looked at allow you different ways of thinking about things, from virtual consultations to in-practice primary care, to referral to secondary care, to working in secondary care, to self-monitoring. So there's really quite a lot of different use cases you can begin to scope and think about. And working through this, you can end up, and this is the sort of methodology Deloitte have used, you can end up with an assessment of where you really want to work your use case and where you want your algorithms to work. And that's one of the bits of work we did right at the start when we set up our consortium, really trying to concentrate on those areas which we regarded as critical use cases. So one of the things which David's talk really alluded to was the lack of some of clinical metadata within many of the publicly available data sets. And that presents a couple of difficulties for us. We don't get some of the standardized data we would like. We don't get perhaps some of the clinical information we like in a standard and uniform way. And so we want to be able to have data in the real world coming into our systems in which we've captured this information in a uniform way. We've captured clinical information in a uniform way. We've captured lots of the bits that are really important to understand, things such as skin types, things such as social class, things such as geography, where the patients come from. So we've been trying to work on, in the UK at least, working on some of the clinical DICOM standards, thinking about wrapping our data all in a DICOM format and having in that data included prospectively captured data, which captures clinical metadata in the same way. And that prospective data begins to give us real world use, but in our setting begins to give us inclusive databases. The reason for that is in the NHS in Scotland, in our area, 96% of people only use the NHS for their healthcare, and of the remaining 4%, only a very few of those, perhaps one quarter of those, or 1% of the population, go for skin cancer care to the private sector. So we have a very high capture rate in a standard population, which includes, in our population, remote and rural, inner city deprivation, and areas of considerable wealth as well. So we also think that the way to do this is to develop something certainly across the UK and not limit it to one area such as our own, because certainly we don't have the variety of ethnicity, for example, that you might see in central London or Birmingham. So what we're trying to do is standardize this pipeline of data so that the data set comes in, we can begin to really produce the prospective, real world, inclusive, standardized data sets with standardized clinical metadata in a DICOM format. And if I was to give an example of some of the standardization, this is just one little bit of it. There's many, many elements to it. But if you're wanting to teach people, they've got to go through a course now, how to use their dermoscope, how to take pictures. We've got various teaching aids which show them how to use things in a standardized fashion. So it's not just the equipment, it's the people as well, all need to do things in the same fashion to bring in this database in the same way. I got a little bit stuck on this. There we go on. And so this is just examples really from one of our work packages, which is about training non-experts. Actually, we're not training clinical photographers in many of our situations because we're trying to capture data close to home for the patients, and some of our patients live quite far away. So this is the sort of thing which we're doing to try and bring in that standardization. So let me just move on. So I think given the time constraints, I'll probably just leave it at that, but I wanted to just broaden some of the thoughts round about clinical data sets today, to think about how clinical data sets used. I think the use case is really very important. We've got some ideas locally of how we think we can overcome some of the obstacles which exist in terms of trying to capture real-world inclusive data sets. And of course, this is, like everybody else's work, an enormously multidisciplinary project involving AI, data scientists, clinicians, researchers, but also lots of clinicians labeling data and helping out with data, as well as the inevitabilities of digital infrastructure, information governance, and all the other colleagues that you require to implement artificial intelligence. So I'm just going to leave it at that, but be happy to take any questions. I'll stop sharing.
Thank you. Yeah, thank you so much for